Hello, my name is Ian McCall, and this is a talk about the histopathology of squamous cell carcinoma. Now, most SCCs that we see here in Australia occur in sun-exposed areas. However, not all of them. Some that occur in genital areas especially may be associated with the human papillomavirus infection with various oncogenic serotypes. What we're going to do is have a little look at some clinical images of SCCs and the corresponding histopathological picture. But we might do it in this particular fashion. This is an SCC that's occurring on a background of extensive solar damage on the lip. There's excess keratinization. Remember that in an SCC you've got an abnormally proliferative epithelium. And if you look at it histologically, this is the sort of picture you see. You have these buds and strands of atypical epithelium extending down into the dermis, and in amongst them you have these keratin pearls. Because remember, keratinocytes are essentially there to produce keratin to form the normal stratum corneum, and even abnormal keratinocytes will form keratin. When you see keratin pearls like this, though, it's regarded as a well-differentiated SCC, because as the SCC becomes less differentiated, then the capacity to form keratin decreases. This, of course, is a much more aggressive squamous cell skin cancer. Note again, I've put it on a lip, but you can see how there's complete loss of the epidermis here with ulceration and a thick invading tumor. Remember, these tumors can invade to the local lymph glands and can even go systemically. So always check the local draining lymph glands. Here, always check under the chin and the mental lymph glands. This is a picture of a more aggressive SCC. There is still some keratinization here, but you can see this has invaded almost down to the fat layer here, and it would have ulcerated as well. The epithelium, when you look more closely at it, will show atypia of the keratinocytes. There will be nuclear atypia as well, variation in the size and shape of the nucleus, and you may well find mitoses in this. And the less differentiated an SCC is, the more mitoses and the like you're in fact going to see. Now, with SCCs, the less differentiated ones can obviously spread via the lymphatics and certainly even into blood vessels. There are several different types of growth patterns that can be seen. You can have a desmoplastic SCC where you've got really a marked fibrosis in the stroma. You can get a neurotropic SCC that's spreading along the sides of nerves, and you can also get an acantholytic SCC, and I think we have some images of that a little bit later on. However, let's look at a different type of SCC. This one isn't showing a lot of keratin, and usually this variant in fact does. What you do is put a dermatoscope on it, and when you look at it, you'll see a lot of these coiled glomerular vessels. And when you have a pattern like this, it's likely to be an SCC in situ, or Bowen's disease. Let's have a little look at the histology. At this scanning view, this is a shaved biopsy, you can see that there's acanthosis of the epidermis here. It's thickened. And the reti tend to be rather bulbous at the periphery here. And if you go in and have a closer look, then you see a variety of factors. These are these bulbous reti that we talked about, the acanthosis of the epidermis. You have some parakeratosis here with nuclei in the stratum corneum, but you've got marked disruption of the cells in the epidermis. you've got varying sized cells, and usually they have a larger nuclear to cytoplasmic ratio than normal. Generally, note how all the atypia, though, is confined within the basement membrane. There's often a pushing effect on the basal layer of cells here, and these can be thinned quite significantly. But these haven't invaded into the dermis, and this is all SCC in situ. Within this, you may be able to see areas of mitoses, and you can often see atypical keratinocytes either in clumps or singly extending up into the epidermis, and perhaps that's more seen in the next view. So here you have this buckshot scatter of atypical keratinocytes. These are your more typical keratinocytes up here, and there may still be desmosomes linking the cells up here, but in these ones there won't be. These are your atypical keratinocytes with the little clear area round about the nucleus. And often, if you were to look carefully through this, you'd see perhaps a mitotic figure or two, or three for that matter. Sometimes you'll get clumps of these atypical keratinocytes as well, and occasionally you can get a clear cell change. But this is the picture of an SCC in situ, and it's the same picture if you have this on a mucosal surface, particularly on the penis, where this tumor, an SCC in situ, will present as a glazed red plaque with very defined edges that slowly increases in size. It's possibly due to the HPV virus, but it's the same histological picture that you'll in fact see. Now, when you have Bowen's disease or SCC in situ like this in a hair-bearing area, the tumor also goes down the hair follicles and goes down quite a significant extent. Rarely you can get some SCC just confined to the hair follicles with a normal area of epidermis intervening. And some people say that's the more typical picture of true Bowen's disease, but I really don't think it is. Let's have a little look at this image here. This actually is a big porokeratosis. It's not an SCC, but sometimes in the center of these, after some time, an SCC can develop. And this one shows some red circles in the dermatoscopic view, and it's a picture that you can see in an SCC in situ, as well as the glomerular or coiled vessels. Another type of SCC you can see is a Verrucous carcinoma. Now, as the name implies, this often looks like a large wart, and there's quite excessive keratinization, as is the case here. But this is really a well-differentiated SCC, but it's very slow-growing, and it pushes into the dermis, or at least it pushes from the epidermis inwards. Most of the time, this can still be confined to the epidermis, and only later on does it, in fact, break down into the dermis itself. If we look at the histopathology of this with a Verrucous carcinoma, you can see this marked papillomatosis. You've got quite a bit of proliferation of the epidermis here as well. The edges tend to be rounded at the base, and you've got pink, well-differentiated epithelial cells here. There isn't the same, if you go in and look at these closely, there isn't the same degree of atypia as you would in fact see in Bowen's disease or in true invasive SCC. You've still got marked keratinization occurring here within the lesion, but you generally won't see a lot of mitoses, and you won't see a lot of variation in the size of, and shape of the nuclei of the keratinocytes in this area. And here you've got the keratin and the interstices. The other variant of SCC that you're going to see is the Keratoacanthoma. Now, this usually is rapidly growing. It can occur after a biopsy of something. It can occur after a solar keratosis is frozen. It sometimes occurs at other sites of injury and sun-damaged skin. But it often will double in size in a 2-week period, and characteristically has that rounded edge, may have even a little collarette there where it attaches to the surrounding normal epidermis, but it always has this central keratin core. It's a well-recognized clinical feature of a keratoacanthoma. And if you look at the histology, again, marked keratinization here in the center. You've got this invasive proliferation of these glassy pink keratinocytes. So the pinkness indicates that there's still keratinization occurring in this. But really, to diagnose a keratoacanthoma with any certainty, you've got to see the base of it. Because when you look at the base, generally, again, you have rounded basal areas, and they tend to point in the way, as if they're all going to meet at a central point down here. So these proliferating strands of epithelium point inwards. Again, there isn't, some mitoses can be seen, but there isn't the same degree as in a squamous cell skin cancer. And you still, as I say, have this pink keratinized epithelium that pushes down as it grows. It pushes into the dermis. Now, I think it's best to regard this, though, as a variant of a squamous cell skin cancer, one that's almost able to differentiate to such an extent that it ultimately involutes, because a lot of them will involute, in fact, on their own. You can get a syndrome with multiple keratoacanthomas erupting, and it may be a marker for the Muir-Torre syndrome, where you have multiple keratoacanthomas and unusual sebaceous tumors and associated underlying malignancies. The cupping that we spoke about earlier on refers to the interaction of the edge of the normal surrounding epithelium with the keratoacanthoma itself. As I've said, you've got minimal nuclear pleomorphism here and few mitoses. And you may sometimes get collections of neutrophils, little microabscesses within the lesion. You almost always have some degree of inflammation, of an inflammatory infiltrate, mainly lymphocytic, and sometimes also eosinophils at the base of a keratoacanthoma as well. But remember, there's no certain way of differentiating a KA from a well-differentiated SCC, and some pathologists will just report them all as well-differentiated SCCs. The important thing is that you give them a specimen that allows them to see the base of it. So not a little shave, or if you are going to give one, make sure it's a shave that's going to take the whole lesion out, so that they can see the base, because the pathologist needs the base to be able to say that something's a keratoacanthoma. This is just another view of the base. Another little feature here. A KA tends to push the surrounding eccrine glands. It doesn't infiltrate into them, whereas an SCC will. It tends to push them away from the advancing edge of the keratoacanthoma, whereas an SCC will tend to invade these eccrine glands. The other little feature, now this isn't keratoacanthoma. Why? Because it's got acantholysis. You don't get acantholysis, separation of the cells, in KA, but you will get it in an SCC. And an acantholytic SCC means the SCC is showing signs of acantholysis, or separation of the cells in the epidermis. Now, there are some other variants of SCC. This one. Here you've got a bit of keratin on the surface here, but not a lot. And these lesions have come up relatively suddenly. The sun-damaged scalp of elderly males is a fertile area for the development of SCCs. And when you do a biopsy of this, you may get a picture coming back like this, where the epidermis is essentially normal. So that's why you don't get an awful lot of keratinization. And you've got all these abnormal spindle cells here, hard up against the base of the epidermis. And this is a spindle cell variant of an SCC. Now, this can be awfully difficult for the pathologist to diagnose. They have to do special stains, immunoperoxidase stains, where an antibody with peroxidase attached to it latches on to a particular antigen. And there are, you see, spindle cell tumors can be melanomas, atypical fibrosarcomas, poorly differentiated SCC, and leiomyosarcomas. And there are different immunoperoxidase stains used to pick up either muscle or pick up the cells in an atypical fibrosarcoma, or the S100 cells that you might see in melanomas. Here you have another poorly differentiated SCC, smoothish on the surface, but no keratin here. This was a patient who had had bilateral advancement flap for an SCC, poorly differentiated SCC, but this tumor had already spread and was spreading along the lymphatics here. And if you look at the pathology of a poorly differentiated SCC, it can look somewhat like this. Look at the degree of nuclear atypia within this lesion here. And this one is getting down, this is muscle. This one's invading down into muscle. So poorly differentiated SCC have a propensity for deep invasion, and they have a propensity to go along nerves, and they don't form a lot of keratin, because you need to be well differentiated to form keratin. So this is the other type of SCC you can see, an undifferentiated or poorly differentiated SCC. Remember also, you can have lesions that look like SCCs, but they're metastases from elsewhere. And generally, these lesions won't have any attachment to the overlying epithelium because they're metastases. So, SCC, it's Keratoacanthoma and Bowen's disease. They're interesting tumors. They're all epithelial tumors, but you can see the marked variation that there is in the in lesions as we flick our way back through this this presentation. I hope you've enjoyed it. I trust you've learned a little bit about the squamous cell skin cancer and its variants. Thank you very much.